This is my study review of bilateral neuromuscular adaptation to acute unilateral resistance exercises in healthy older adults for our journal club. For the study, there's a little bit of background information needed to better understand it. One of them is the phenomenon known as cross-education, where unilateral training results in muscular benefit in the equivalent non-exercise limb. For example, if I worked out the bicep on my right arm, my left arm, even without exercise, would receive some marginal benefit. Similar to this is another phenomenon known as cross-limb transfer fatigue. However, it is not well studied. Also, in aging adults, resistance training is critical to their physical wellness as well as recovery from injury or illness. Now, the purpose of this study is to address the knowledge gap in how resistance exercises in aging populations of adults affect the cross-limb transfer of neuromuscular function and motor unit adaptation. Now, for evaluating whether this study was credible or not, this study was posted in the journal Neuroscience, which has an impact factor of 5.3 and a 5-year impact factor of 6.2. There were no citations yet, but this is due to the extremely recent publication date of the 8th of May 2025. The writing was clear and concise, and no major grammatical issues were present. There was a thorough statistical analysis that corresponded properly to the data. The authors were all credible and had previous publications. The figures were fully labeled with comprehensive captions, although one note is that in the paper, some links that directed you to a figure or table didn't go directly to the table or figure, just on the same page as it. And there were 61 references referenced in the paper, which all relate to the background or discussion of results. The participants in the study were 13 healthy older adults, which was comprised of 8 males and 5 females with a mean age of 74.9 years old. Before the exclusion criteria, there were 17 patients who were screened, and the exclusion criteria includes a BMI less than 18 or greater than 35, if they were diagnosed previously with disease or disorder in the past 6 months, or if they participated in a structured training program in the past 6 months. This exclusion criteria excluded 4 people from the study, giving us a number of 13. Now, the only possible selection bias based on this exclusion criteria was that they didn't include any ill or injured patients with significant injury or significant illness, so our subjects are only representative of the healthy side of the older population. Now for the methodology of the actual study. As you can see in the upper right corner, I cropped a flowchart that shows how the screening and study day procedures were performed during the study. Now, the terminology we'll need for this is MVC stands for maximum voluntary contraction, which correlates to a patient's 1 rep max at 100% MVC. FS is force stability, IEMG is intramuscular EMG, and HDS EMG is a high-density surface EMG. Now, during the screening visit, that was when patients were excluded based on the exclusion criteria. The 1 rep max was found, and a muscle ultrasound was taken. To determine that 1 rep max, the patient did a quick warm-up of leg extensions, and the leg extension was classified as the patient at a resting position has their leg at 90 degrees, and then they extend their leg all the way to 180 degrees with a certain amount of weight. They then did a leg extension at 80% MVC, or 80% of their 1 rep max, and then they rested a minute, and they increased the weight and repeated this procedure until the patient failed, which was considered their 1 rep max. Now, during the actual study day, the pre- and post-evaluation, they randomized each one of the tests taken, and each measure was performed on both legs as the patient performed an isometric leg extension hold at 25% MVC. For the actual intervention, the patient performed 12 reps at 75% MVC for as many sets until failure with 1 minute rest in between. And failure was again classified as the inability to complete the full range of motion of the leg extension, so going from 90 degrees to 180 degrees. The pre and post tests were performed on both legs, while the intervention was only performed on the exercise leg. For the ethics of the study, the ethics was approved by the Research Ethics Committee of the institution. It followed the Declaration of Helsinki, and patients gave written consent before the study. Now for the results and analysis of results from the study. On the left, I've included a screenshot of the results table from the actual study. And to start off with the analysis, the data was cleaned using software such as DEMUSE and MATLAB. The HDS EMGs were filtered for noise, which means that only signals with a pulse-to-noise ratio above 30 were included, anything less was excluded. The IEMGs were decomposed using a software to find muscle unit recruitment and derecruitment and plateau. Now, for the actual statistical analysis, they used a linear mixed effect model, which looked at the effects of time, leg, and leg X time. From there, the estimated means were found using post hoc tests, and the corresponding tests which fit the data type were performed on the different data sets to find the significance. And all significant results were indicated with an asterisk. So if you look at the table from the study, in the first row with the MVC, you can see that the time and leg X time had a significant effect. And with force steadiness, only the leg X time had a significant effect. Now, although the study did test for and mention the number of muscle units recruited, as well as the firing rate recruitment, derecruitment, plateau, and variability, the main focus was on the categories under functional assessment, as this is where the cross-transfer fatigue could really clearly be seen. Now, for what these results actually mean, if you look at the table I created, we can see that compared to the baseline before the intervention, the exercise leg had a significant decrease in MVC and had an increase in MUFR, which stands for motor unit firing rate. Now, this was expected because as a muscle is exercised, its maximum voluntary contraction is going to decrease as it fatigues. And to compensate for this, the motor units will begin firing faster. However, what is surprising is that in the control leg, which underwent no resistance exercise during the intervention, still showed a decrease in MVC, however showed no change in MUFR. What this means is that the control leg still became more fatigued, but did not show any neuromuscular adaptation in terms of firing rate. So what this study showed is that a single cycle of resistance exercise is enough to cause cross-limb transfer of muscular fatigue, in our case from the exercise leg to the control leg. Now, motor unit adaptation, which was the increase in firing rate, was only seen in the exercise limb and not the control limb. This actually opposes a previously proposed idea that the cross-limb transfer is related to the central neural drive, because if this were true, that would mean that the control leg would also show an increase in motor unit firing rate. Now, the authors suggest that the non-localized fatigue may be a result of a release of fatigue byproducts into the systemic system or the bloodstream. For example, as the muscles in the exercise leg fatigued, they released heat shock proteins and lactic acid, which they theorize was picked up by the bloodstream and then later transferred to the control leg, which caused some sort of fatigue. Some limitations of the study was that the study was only an immediate analysis of muscle adaptation, and it doesn't generalize to all interventions. So if you're doing a long-term strength training program, or if you're training for endurance, these results cannot be generalized to those types of training. Now, the recovery post-intervention may also have affected the results, although efforts were taken to minimize these effects. After the intervention, muscles naturally recover, and so although the tests post-intervention were randomized in order to not skew the data towards one test or the other, there's still a chance that the muscle recovery happened quick enough to have a slight effect on the results. Also, this study did not include any younger healthy subjects, so the results cannot be applied to them, and the study was unable to determine the mechanism behind the cross-limb transfer. The significance of the study is that the cross-transfer fatigue may influence results of EMG testing if not carefully corrected for, such as by performing bilateral movements or only unilateral measurements. The study addresses the knowledge gap of how resistance exercises can play a role in cross-transfer of fatigue in older adults. This can especially be useful in recovery after injury or illness and maintaining a healthy lifestyle for this population. With the detailed methodology and analysis, and given the proper instruments, this experiment could be easily replicated. This study sheds more light on the effects of cross-education in contralateral limbs, however, emphasizes that the underlying mechanism of this phenomenon remains unknown.